So welcome to this session. We're going to talk a little bit about something that I think is near and dear to all our hearts, which is competition. And I think what we've heard a lot in Washington lately has been tech competition. We don't necessarily think of it as a healthcare issue, but we've got massive challenges in competition in healthcare. And so I'm excited to be with these guys because they're the experts. I kind of dabble, but what I wanted to start things out with is just kind of like, let's give people like a snapshot of what the problem or the challenge is, because I think it's underappreciated in Washington, D.C., how big a challenge this is in healthcare. And I'll just kind of throw that open as, from your perspective, what's the issue?
Go ahead, Jay. Sure. I mean, I think so. There's three parts to healthcare that are big players. There's doctors, hospitals, and drugs, and every healthcare analyst you look at will come and say, well, this is the problem, this is the problem, this is the problem. To me, the key question is there's a asymmetric information problem, right? You go see doctors, you go to healthcare because you want to get better, and you don't know how to get better, or you want to find some treatment. And normally in markets, you have prices that give incentives to manage relative scarcity. Right? The prices reflect the value of the thing you're getting. Prices reflect the scarcity of the thing you're getting. In healthcare, that is not the case. The markets do not work in healthcare that exist as they exist because the prices don't reflect relative scarcity. You have tremendous intervention by governments to essentially administer prices, like Medicare administers a vast set of prices for relative for manage for what doctors get paid. You have markets on the other side that are just not competitive, like just straight up not competitive. So you have like monopoly, effectively monopoly pricing, a local monopoly pricing. And so the prices don't reflect relative scarcity. And so you have this deep dysfunction. So to me, the right way to think about this is how do you restore processes that bring back prices that reflect relative scarcity, and that would be true whether you have a market system or you have like a Medicare for all system. And if you don't have an answer to that question, you don't have an answer to how to reform healthcare.
Guy or Avik?
Guy, go ahead. I'll go last.
Thank you. I think there are two dimensions to the problem, right? First one is horizontal. So hospitals buying small hospitals become bigger hospitals. The other one is vertical. So hospitals buying physician practice and then make the vertical your one-stop shopping. And the problem is you're being controlled and the price got very high and very hard to negotiate down price. So I think those are the two dimensions of this lack of competition and then increasing price and monopoly power issue. Thank you.
Avik.
Well, that was very concise. I would just add this. I mean, the consolidation problem is incredibly important, as we're all alluding to, and I want for the non-healthcare people in the room who are just kind of being introduced to this issue. I just want to emphasize this because there is this kind of free market libertarian doctrine that antitrust policy is bad. That if you are the FTC or you're the DOJ and you're trying to break up monopolies, that's a kind of government intervention, and we should be against that. We should let these monopolies exist, and there's this kind of this whole theoretical doctrine that, well, monopolies aren't real in libertarian theory because at the end of the day, if you're a monopoly, you're going to engage in bad customer service and charge too much, and some competitor will come along and defeat the monopoly because they'll deliver the product at a lower price or with better quality. The problem is that it costs a lot of money to set up a hospital. And in many parts of the country, you're not legally allowed to set up a hospital until the incumbents actually agree that it's okay to set up a competitive hospital. It just doesn't happen. These are called certificate of need laws. But the bigger problem, I think, intellectually, the problem that I think a lot of us need to get our heads around is that if we want there to be a free market for healthcare, there actually is a role for the government in attacking anti-competitive monopolist behavior. And that's something that I think not everyone in this room necessarily believes at this moment.
So I want to go back to something you said about hospitals, doctors, drugs. And for the past 20 years, I feel like all we've talked about is drugs, right? It's just nothing but drugs. And there's issues on drugs in this space, obviously, 340B being the prime example. But drugs are just 10% of the healthcare dollar, right? We've got 90%. it doesn't seem like policymakers are really spending a lot of time and attention to, right? And yet I could drive from here today over to Seattle, down to San Diego, and then over to Miami, and never drive through a competitive hospital market in the United States. Why is that? Why aren't we paying attention to this?
So let me just give I started with I think a more pessimistic picture, but I want to give like some optimism, because I actually think that we have the health policy tools to potentially solve this problem. There was a law passed in 2015. It was a bipartisan law called MACRA. I don't know if there's a few people are nodding in the room, but weirdly unknown outside of health policy geeks. That you self-identified yourself when you nodded to MACRA. So the idea of MACRA was that you should have all doctors who accept Medicare will have a choice. They can either join an accountable care organization, which is like an HMO-like thing, or where they get paid via how the organization pays, or they subject themselves to a report card, something called MIPS. Now, MIPS is what it's in principle supposed to do, is supposed to give for every doctor that signs up for, which is basically most doctors in the country, a report card that says your costs are high and your quality is low. You're going to get a 9% ding to your Medicare Part B payments. If your costs are low and your quality is high, you get a 9% bonus. It's an 18% swing. That's a lot of money at stake. The problem is, how do you do the report card? That's the tool, I think, is the key thing, because doctors control drug spending, doctors control hospital spending. What you do is you create an episode group, so that for every single important kind of service a physician provides, you have essentially a consensus statement about what should you expect out of it for patients. And you group all of the things that can happen to patients into an episode, and you say, okay, well, I did a cataract removal, and it turned out you need a lot of occupational therapy. Well, that's a negative quality indicator, and so you'll get a ding in your statement. Or the patient goes blind. That's a negative quality indicator, and you get a ding. If you include drugs in that, if you include hospitalizations in that, then you have essentially one actor who controls all the resources on the hook for excessive costs or poor quality outcomes, and they get rewarded or punished for that. That, I think, is the right structure, because you have to say who in the system has the most information, and then put the incentives on that actor. In this case, it's the physicians. The physicians have the most information. You create a system of payment and rewards and harms for people who don't, rewards and penalties for people who make to do well or do poorly, and that's how you restore potentially this idea of relative scarcity back in the system. Because right now it's utterly broken.
So, Guy, I want to ask you, because you've done some work here. If physicians are making the decisions about where the patient goes and how they get treated, and ultimately the outcome of that patient at some level, MACRA has been around since 2015, I believe it was enacted. How well has it worked? Bad. But how can we change that incentive? Because it seems like what you're saying is the problem is really a market structure, a legal entity type ownership arrangement. And what we're seeing in the physician market is, in some specialties, 60, 70, 80% are employees of the hospital, and increasingly primary care and specialty care they're selling their practices, changing the name on their door, and becoming, a more higher paid employee of the hospital. What's the answer there? Is that a antitrust busting type thing, or is it a payment issue where we can create incentives where physicians can figure this out?
So in my opinion, this is a very automatic response to market incentives. So why would the big ones eat the small ones? Because both are benefiting from this transaction, right? Voluntarily. And who's creating the incentive? For the bigger ones to want to swallow and the small ones want to join? I would say among many factors, government is playing a major role in creating the incentives. So number one, let's look at 3 dimensions. The first dimension, The government is making the bigger ones' life really good. Think about 340B program, right? If you are for-profit hospitals, you just cannot join, no matter how much good things you have done. I'm not saying they're doing good things, but I'm saying you are just not allowed to join, right? So 340B is designed as a buy low, sell low program, helping hospitals with disproportionately high disadvantaged patients. But now because of what? Buy low, sell high to all patients. Okay, so if you're a small potato, you definitely want to join the big ones, right? It's a huge incentive for you. Okay, or look at the nonprofit hospitals. They have a lot of tax subsidies. Among them, the biggest one, in my opinion, would be property tax exemption. So if you can join, if as a physician practice, you join a big hospital chain under the name of nonprofit, all your property tax exempted, right? And then Medicare is providing this incentive for physicians to join hospitals by paying more to in-hospital, outpatient hospital service, while paying low to the same service provided by physicians. So this is just an example of how the regulations are creating incentive for the bigger ones to enjoy a great life and the small ones to suffer. So creating incentive for the small ones to join and the big ones to swallow.
So if I can top line that and then switch it to Avik. So 90% of the hospital market is highly concentrated, right? You're saying there's a market incentive for the big guys to swallow the small guys and to buy the physician offices. And then there's government policies, regulations, and reimbursement on the table that incentivizes that kind of transfer from small to big. Avik, what do you think?
Yeah, your original question in this round was, why is it that we're not paying attention to the 90%, we're only paying to the 10%? I would tweak it a little. It's more like 85-15, because actually the 10% of health spending that's drug spending is retail drug spending, what you buy from a Walgreens or a CVS. There's another 5% or so that flows through doctors' offices or hospitals. So drug spending is more like 15% of the total. But you're right that hospitals is more like 30% of the total. So why aren't we paying attention to that? And I would say that a big part of it is actually the political corollary to what Gu was saying, which is that the for-profit healthcare sector gets a lot of scrutiny from the left, which assumes that if you're nonprofit, you're the good guys, and if you're for-profit, you're the bad guys, when in fact, both the so-called nonprofit entities and the for-profit entities actually seek a profit. It's just that one group of them are tax exempt and the other group is not. Go to any hospital. We have Jeff Blyer in the audience, who was the dean of Harvard Medical School. You don't think that Brigham and Women's and Mass General cared about how much money they made? I guarantee you they cared a lot about how much money they made. That's all they talk about, in fact. And so it's not really nonprofit versus for-profit. It's more tax-exempt versus taxable entities. And that's something I think we got to look at is this whole idea that you can call yourself a quote-unquote nonprofit and thereby somehow have this halo effect where you can do whatever you want. You can actually be more exploitative of your community, of your patients, and it's okay because you're a quote-unquote nonprofit. That's a real political blind spot in our system. So that's definitely an area we gotta spend more time on in general. And I would say the other thing that everyone's highlighting that I just want to draw a circle around is, I think among people who don't spend time in healthcare, and I know there are a lot of sophisticated healthcare people in this room, but among people who don't spend time in healthcare, who are of a libertarian or classical liberal orientation, there's a sense that we have a free market healthcare system, and all these people on the left who want to make healthcare universal or something, they're the ones who want to introduce the government into healthcare. The government has a massive, massive role in healthcare, the dominant role in healthcare today. We do not have a free market healthcare system, and so there's a really, really important role for reformers to change that in a way that would make healthcare less expensive.
Can I address that real fast? Because I was giving you my experience with working with the Center for Medicare and Medicaid Services to implement the macro legislation. So I've worked before the pandemic once upon a time. I worked on designing the report cards that doctors would get judged on. And what I saw was, first, there was very little effort by the CMS to actually implement the system. In order to do this right, you need, like what doctors do is that there's an incredible array of things that doctors do. In order to do a real report card, you have to get clinical consensus on nearly everything common. that doctors do. So the creation of these involved inviting expert doctors from lots of different societies to come in a room together and say, okay, well, if you I'll just go stay with the cataract thing. If you did a cataract service and the patient goes blind, is the doctor to blame? Is the thing that happens after the cataract service does that something that you could put on the blame on the doctor, or suppose the patient gets hit by a bus after the cataracts? I mean, okay, maybe if they went blind, it's the problem. I don't know, but but you'd have these physicians debating with each other about whether the services that came after the initial service belonged to the responsibility of the doctor, whether or not they were actually delivering them. You need to do this for like hundreds and hundreds and hundreds of activities that doctors do in order to get a real report card. In 5 years, we got 30 of these episodes out. Medical societies, many medical societies, who have tremendous control within CMS, worked very hard to slow down the development of these. You have essentially a regulatory body that is captured by the people that are regulating, and it is a fundamentally broken system. And what Avik said is absolutely right. It is the role of government is tremendously important in healthcare. You cannot overemphasize it. We have, and I actually don't think a pure free market system could work in healthcare. You need government involved. But the question is, how do you reform the government's involvement so that it's constructive rather than destructive? Because right now what it serves is the interest of the people inside the system, physicians, drug companies, hospitals, not the patients.
Let me riff on that for a minute, because I think it's on.
Yeah, it's on.
Yeah. Let me riff on that for a minute, because I think this is a huge point. I do a lot of advocacy around healthcare, and we don't have a free market in healthcare. I think we can get to freer markets, maybe not free market purely. I'm not sure any of those exist in the world, but 50 cents of every dollar in healthcare comes out of Washington, D.C. Every dollar in healthcare is regulated by a rule in Washington, D.C. And we often say, well, we want free market healthcare. And people on the ground, patients, experience healthcare and all the negative stuff that comes out of government regulation and funding, and they go, if this is free market healthcare, I want single payer. I want public option. Because this doesn't work for me. We got to do a better job explaining we don't have free market health care. It's the government that's making these markets not work well, and we need to get to freer markets is kind of point number one. But point number two, and there were a series of political decisions made with respect to your legal tax status as a hospital, and you've highlighted some of them. The first is I get a tax benefit if I organize a nonprofit, right? And it's significant. I also get access to 340B pricing if I'm a nonprofit. If I'm a for-profit hospital, I don't get 340B pricing, right? If I'm a hospital, I get paid more than a physician office for certain services. So there's a difference in the site of service. So I have all these advantages if I organize as a nonprofit, because someone politically once blessed a nonprofit and said, you're better than for-profit because we don't like making money in the market or something. But a long time ago, I was the staff director of the Ways and Means Health Subcommittee, and we asked MedPAC to take a look at the deal that nonprofits got. And the trade-off in your tax status says you're not going to get taxed, but we're going to expect you to provide charitable care to the community. There's got to be a community benefit as a result of getting a tax break. And MedPAC looked at, by tax status, how much charitable care was provided. The top was a government-run hospital, and so counties have hospitals, states have some hospitals, et cetera. Top, right? Not surprising because it's the state. Second on the list was for-profit hospitals. They provided more charitable care than non-for-profit hospitals. I'd love to see MedPAC reissue that, issue that study publicly, because we are asking for that trade-off as a society. We're saying we'll give you taxpayer dollars as a subsidy to be a nonprofit, but we expect you to do community benefit. And the other side of that also, and I think Brian Blaze and Grace Marie Turner and others have highlighted this, is that the community benefit can't be nonsense. I was going to say another word that began with a B and ended with a T. But some hospitals will put up a bike rack in front of their hospital and say, that's my community benefit. Like it was intended to be charitable care. It was intended to, have some major impact on the community. So how do we change that? Sorry for riffing so long, but how do we change that political dynamic? Because I think people don't know. I think people mischaracterize the market, and then I think there's a political decision that's been made that we want nonprofit, not for-profit in healthcare. And maybe Avik, that's probably a good question for you.
Yeah, it's a great riff, and totally agree with the premise of it. It's a big problem. I think I'll tell you a story. I was doing some work on Indiana hospital reform with some of the people that we all know in the healthcare world, and we were visiting a bunch of the hospitals in the area to understand why it was that Indiana actually has the highest discrepancy between what Medicare pays for hospital care, which is relatively standard, and what the private insurers were being charged by the hospitals. It was like 3 or 4x. If you're privately insured, you're getting charged 3 to 4x more for the same care as if you were on Medicare. Which is one of the things that tells people, hey, let's have Medicare for all because it's cheaper, right? So we were talking to some of these hospitals, and one of the nonprofit hospitals were like, because we're asking them, okay, so why is it so expensive to get care here? And the hospital CEO says, well, it's because of the insurance companies. We have to spend all this time fighting the insurance companies because we try to do something and then the insurers say no, you need to get prior authorization for that, or we don't agree with what you did over there, and so we're not going to reimburse for that, and then we have to fight them, and that's why our healthcare is so expensive. And so I asked the guy, I said, okay, so how much do you spend on claims adjudication? Fighting these insurers? And he said about $2 million a year. I said, and what was your revenue last year? And he said $2 billion. So I'm like, okay, claims adjudication was 0.1% of your overall revenue. And how much did you spend on your community benefit? Like they had all these slides in their deck about the public schools that they kind of funded and all this stuff. Like, how much did you spend on your community benefit? $1.5 million. Right, so the tax break is like 30% or whatever it is. It's hundreds of millions of dollars, and they're spending a pittance of that on all these other things, and it's a big problem. And so one of the things we could do. So there's the idea that we floated out there at FREOPP and that's been introduced in legislation is, what if we had a system where if you were in a very concentrated market and you were trying to do a merger to basically make that market even more concentrated, say, for example, what if that meant you lost your tax exemption, right? If you're gonna be a monopoly, then we're not going to subsidize through that through the tax code, and we're gonna regulate you more like a utility, just like if you live in a place where only one company is allowed to deliver water to your house. We don't just say you can charge whatever you want and those homeowners have to just take it. This is kind of economics 201. We actually say, no, if you want to have that monopoly power, you have to actually be accountable for exploiting that monopoly power to overcharge people. And so hospitals can then decide, do I want to be a fragmented competitive market where we compete on price or value, or do I want to be a utility company? And I would like to think most CEOs who have high opinions of their capitalist street cred would want to compete.
Let's just go right down the line here because we're unfortunately we don't have a lot of time. We've highlighted a lot of problems. How do we solve this?
Great. I still think government regulation is a major reason. Let me briefly talk about the physician-owned hospital. So ACA banned physician-owned hospitals from getting started. So there's no new construction. So we just published a paper on radiology. Think about the hospital's price variation for radiology services. There's a huge incentive, untapped energy among physicians to start their own business to compete with hospitals to provide affordable care. But it's not allowed. And the same thing with certificate of needs law. So there are a lot of barriers created by regulation to make the small potatoes' life very hard. And also think about the any willing provider law and those network adequacy with the state licensing, with the scope of practice. Those things are literally tying the hands of insurance company from them, preventing them from rewarding good providers and punishing bad providers. So once we got those things relaxed, I think we'll see more competition and we'll see a better and more promising pricing situation. Thank you.
Jay?
Thank you. I think you're hearing a lot of agreement on this, maybe not surprising, but one thing I want to emphasize about the regulatory reform, it's important even if you support single payer. Even if you support single payer, in fact, it's even more important if you support single payer. The regulatory reform is a precondition for both markets in healthcare working and also for single payer in healthcare for working. So it's I think an area potentially of consensus, or at least cooperation between people of very different political stripes.
Before I answer the question on the solution, I want to give a shout out to Greg Gervin, who's on our healthcare team, leads our healthcare effort. And one of the things that Greg does, among others, is he runs a project that we have called the World Index of Healthcare Innovation, where we look at healthcare systems around the world on quality, sustainability, choice, and innovation, technological and scientific innovation. And it shows that, look, there are things we can learn from other countries. So in terms of like what's a step toward the solution, not an actual solution, we should not be afraid to learn from countries like Switzerland and Germany and the Netherlands and Singapore that have arguably more free market models than we do. Israel, Ireland, these are some of the countries that under Greg's research have ranked higher than the U.S. on these metrics of markets and competition and choice and quality for patients. So that's one thing we can do. We can look around the world. As I mentioned, we have these legislative initiatives that I encourage you to look at on our website on how to actually bring more competition to the hospital space. The other thing I might mention that's honestly just kind of something I'm riffing on just from something you said earlier, Joel, is you mentioned the fact that right now we incentivize hospital consolidation or consolidation of hospitals and doctors' office by saying if you're a hospital, you can charge more for exactly the same care just by calling yourself a hospital. Well, what if we flip that around? What if we said you would get paid not the same, because most of the reformers are saying let's make it site neutral. Right, we call it site-neutral payment. Pay the doctors, pay the same amount if it's in a hospital or in a private setting. What if we said we'd pay the independent freestanding practice more than the hospital? That would incentivize fragmentation, right? Because all of a sudden you're saying, let's get this out of the hospital. Let's get this into a freestanding clinic where people can more compete with each other. And there's actually, other than the pro-competitive element of it, there's a economic rationale too, which is that if you're a hospital, you've got a huge balance sheet, you have a lot of leverage, you don't need the extra cash. And a freestanding practice might. And so what if we said, we're going to actually reward you through the Medicare program for being a freestanding, fragmented, independent a healthcare provider, because that would do a lot to create a more competitive environment.
How do you think CBO would score that?
By the way, disclaimer, I'm a visiting scholar at CBO, so the opinion is only mine, not CBO's. Thank you, Joe.
Notice she didn't answer the question. So, in my mind, I think that, we've highlighted like basically four primary areas of problem. There's the legal structure. I think Senator Coburn, who's no longer with us, had a bill that basically said you had to disclose, and if you didn't meet a standard, you lost that benefit, right? And you're saying something similar, which is a highly concentrated market. If you merge, you lose your standard, tax standard. I think that's a good change. Grassley is on that one too. The second issue is reimbursement, right? We've got reimbursement in Medicare primarily that incentivizes this consolidation. And what you're suggesting, Avik, is let's start thinking a little bit more creatively around that. I think what we saw during COVID was pharmacies step up and take some of the load off physician offices around discrete set of services defined by scope of practice at the state level. That should be a site of service in the Medicare program. And it should be, in my opinion, reimbursed less because they're doing less skillful things. But we could think about that in expanding the supply, because there's a supply challenge here too. And then what I would say finally is on the antitrust side, we really need, I'm in favor of getting the FTC more involved, because we have 90% concentrated markets and prices are 40% higher in those concentrated markets. But there's an interesting idea. I would encourage you to check out Victoria Spartz's website. She's introduced 6 bills related to a lot of these issues: contract clauses, anti-competitive behavior, things like that, dishonest billing. But one of the ideas was something that came up during the consensus group, and we talked about it for a while, and that was getting a state freedom index in healthcare. And a state that didn't allow anti-competitive behavior would get a higher ranking on the index than a state like, I don't know, New York, that prevented new facilities from opening up and things like that. And the idea was if you had a high freedom index, you'd get more money through the Medicaid program. So flipping the Medicaid idea on its head, where you're paying more the more people you get on what should have been a welfare program and a stepping stone to a better living, to we're going to give more money to states that free up their markets and move people out of Medicaid into more productive venues. You won't get 100%, but that money incentivizes behavior, and we want to incentivize states to make their markets more free.
You know, one thing I want to mention, we've been complaining a lot about all the things that are wrong. We should mention one of the most important positive developments that have happened in the last several years, particularly because we've got Andy Bremberg here in the audience, who is a major driver of it, which is the disclosure of prices that are now negotiated between the hospitals and the insurers. Insurers hated it because they didn't want what they thought were their competitive advantages leaking out. The hospitals, of course, hated it because they didn't want to be embarrassed. But now we're starting to get this massive trove of data of what all the hospitals are charging patients via insurers, and there's going to be enormous opportunities for all sorts of both private sector driven reforms that come out of that, and also just more data for us to all monitor. Okay, where is consolidation really driving prices up? We'll know a lot more about where anti-competitive practices are harming patient prices through this data, which we literally didn't have before. The FTC, that's going to enable the FTC to regulate things where they weren't, because they're going to have more evidence. Okay, this kind of merger really does harm patients and drive up prices. This kind of merger is maybe okay, maybe it actually helps patients. So that transparency initiative from the Trump administration is hugely important. I think is probably the most important health reform of this decade.
I wish the Biden administration would aggressively enforce it. A lot of those hospitals are burying this disclosure six clicks deep into their website, and it's not, I want it to be more effective because that was transformational.
Jay has to run to
Jay has to run. We got like 5 minutes. Thank you, Jay. Give him a round. I'll get 3 minutes, so questions, yeah.
I've been struck by how much of this discussion has been on the supply side and regulating supply, and not on the demand channels. An extreme example, Amazon buys One Medical, puts One Medical clinics in every Prime membership, every Whole Foods store, and suddenly they have enough control to decide which members get what care at which sites on what terms. Any thoughts on how the demand side, which by the way should be a FREOPP position given free markets progress, any thoughts on how the demand side, changing the demand side, can get you to where you want to go?
By demand side, you mean increasing the supply of clinics, or you mean the increasing?
I mean, my basically too much health care, not enough health. We've got an oversupply of acute care. So somebody like Amazon, who today is subject to the predatory pricing you're talking about, suddenly has enough market that it can
start to drive efficiencies.
Bid off against each other.
Yeah, look, I mean, let's hope that Amazon can drive some efficiencies there. They certainly have an incredible track record outside of healthcare in doing that. The biggest challenge, the thing that drives all this, which we haven't yet talked about, but is really the root cause of all these problems, is the fact that people not only don't pay for their health care directly, but they don't pay for their health insurance directly. So we get this massive tax break if you're in the private sector. If you get private insurance, you get this massive tax break for health insurance provided from your employer, as we all know, and that you don't even know how much money is being taken out of your paycheck to pay for that. You just know that it exists. And that is a massive, massive distortion, which then rewards all the people who raise prices. So we're kind of doing all this stuff that's effectively a Band-Aid on top of that original sin, which is a World War II era mistake. And we're all kind of like recovering from that. So one way to fix that, and this is another Trump era initiative that has a lot of promise if we can build on it, is having employers, instead of buying insurance for their workers, give workers the dollars to then buy insurance on their own. This is a regulatory change that the wonks know as ICRA QSERA that was again introduced in the Trump administration, that has the potential to revolutionize this problem by saying, you know what, we're going to give you the dollars, you buy your own insurance, you buy the less expensive plan, you get to keep the savings. If you buy a more expensive plan, go ahead. And then the insurers have a massive incentive to drive a harder bargain with the hospitals, because they know that the only way they're going to make more money is by delivering a lower price to patients.
Great. I mean, quickly add. So I think the individual market have to be fixed before that can work. Because right now the individual market premium increase very rapidly. So if you push patients there, you have to make sure it's affordable, right? And also I think adding Amazon, this is voluntary, no coercion, right? They started. I think having an option is always a good thing. If it's not directly benefiting patient, but the deter and the incentivize other players to be more, working more harder would be a good thing. Thank you.
I'm going to grab the last word here. I think this is important. For all the Biden administration's talk about being pro-patient, we have all these programs that don't let the patients share in the savings. If you give them financial incentives in ACOs and some of these other models, they will actually change their behavior, first of all. Second of all, you've got innovators like Sidecar Health that say if you choose a more expensive provider, you're going to have to pay more. If you don't, you actually get a rebate. You get a Visa card in the mail for choosing the lower cost provider. Those are great market developments. I wish CMS said we are not going to allow Sidecar on the ACA exchanges because their network, which is 100% open, you can see any doctor you want. They don't have a network, so they don't fit into the ACA's definition of meeting network adequacy standards. They don't have a network. You can see any doctor you want. So we got a government problem, we got a political problem, we got a market problem, we got all kinds of problems. What we don't have is a problem with the quality of our speakers. So give it up for Avik and Guy.